Your patient is in a cast, screaming in pain that morphine won't touch them. What do you do first? This is how the NCLEX test if you can think like a nurse. Let's break down every musculoskeletal system trap you will see on the NCLEX so that you don't mix it. This is your MSK crash course. In a very short time, I'm going to give you everything you need to pass your NCLEX. Let's dive in. So this is a learning process. It's a crash course, and we're going to go through system by system to figure out what is going on. The first thing we're going to talk about is what? The P's. Know the P's. The P's are something that is very important. The NCLEX will ask you. The 5 P's. What do you think? What are the 5 P's? Your pain, followed by what? Your power, followed by your pause, paresthesia, and what? Paralysis. These are key for MSK. What are those? And what is the function of this? What do they mean if we say 5 P's? All we're talking about is circulation. That's all. It's talking about the circulation in the system. Secondly, it's talking about mobility, whether you can walk, and tell if there is an infection risk associated with what is going on. Now, I want you to write in the comment which of these 5 P's you think will show up first in what? Compartment syndrome. Is it your pain? Is it your power? Is it your pulses? Is it your paresthesia or paralysis? Let me know in the comment section. Drop it and let me know which one you think will show up first. I can tell you is what? What do you think? This is our crash course on MSK. What do you think will show up first? It's paresthesia, because this is the nerves are very, very sensitive and they are the first. And so those are your priority. When you having pain, it's too late. When you have paralysis, it's too late. When there is no pulses, it's too late. Therefore, watch for paresthesia. These are concepts I want you to pay attention to. Okay? Now, let's move to next stage, fraction. I'm giving you key facts that you need for the NCLEX. Straightforward information. And if you know these little things, you'll be fine. The next one is fractures. The fractures, there's certain things you have to know, right? Fractures, certain things you have to know. It constitutes about 80% of your test. The teaching you have to know is one. I want you to write this down. First thing, you got to know how to provide teaching to the patient. And when you're providing teaching, number one is immobilize before you move, right? Make sure when they give you a question, you immobilize the leg before movement. If it's not splintered, you don't move it. Write it down. It has to be immobilized before we move. That's the first thing. Second thing, what do you think? You always want to check, you assess neurovascular status before and after cast. So after cast placement or splint, okay, check neurovascular, which is the way I'm going to write it. Neurovascular, make sure it's intact before and after. This is key. Okay, make sure you can do that. Now, third one. So this is your teaching regarding fractures, key fact. Always elevate, right? To take away the edema, apply some ice, okay? And then assess the individual pain. That is key. And this is what that is key. And this is what you use in the management of the patient with what? Fracture, right? So assess for pain. The next thing you can do is what? You should never insert anything inside the cast. And that's what you teach the patient, and you yourself, you should not do that. So these are the first aspect of it. We talk about the 5 P's. Like I said, this is crash course, trying to go through everything. And fracture, these are your main thing you need to know, and this is what will show up on your test. Imagine you are in the emergency room and somebody show up and he has pain out of proportion of what you should expect. What do you think is going on? And this is exactly what they will ask you. And this is consistent with compartment syndrome. And those are our 5 Ps that we've talked about. And so you'll see a question, what should be your first action? When patients tell you this, what is your first action? What are you going to tell, or what are you going to do when the patient tell you the pain is not relieved by morphine? What do you do? But what do you think? Crash course. If you can loosen the cast, yes. It depends on the way they will frame the question, right? It depends on the way. If it's able to be loosened, you can do that because this is a problem. But the best thing is to notify the care provider and do not elevate, right? I don't want you to do not. If you see the answer, do not elevate because that will take blood out of the leg and cause more problem. These are concepts I want you to master. Your first action, if it can be losing and you don't have to bivalve it because you are not the provider, yeah. But if the small dressing, you can unloose it, fine. But if you require bivalving the cast, that's a problem. The next thing you should do and notify the provider, but do not elevate it. We have a different scenario now. Let's say that your patient, let's say your patient had a femur fracture and suddenly become restless and confused and has shortness of breath. What do you think is going on? So this is what we have. We have a femur fracture. We have confusion. We have shortness of breath. And we have restlessness. What is going on with this patient? I want you to know this triad. This triad is what? We have dyspnea, that means shortness of breath. We have what? Confusion and petechia. That means rash on the chest or on the torso. What do you call this? This is what? Fat embolism. This is a big problem called fat embolism. And what should be your action? Fat embolism. How do you manage this patient? It depends on where you are. But most of the time, what do you think? The patient needs oxygen, you need bed rest, and then you got to let the doctor know, ACP, and supportive care. There is usually nothing you can do. But this is what NCLEX will tell you to do. And this is what you should pick. This is the reason why it's very important to know what is going on. The next thing is immobilized. Immobilize the leg. Make sure the leg does not move anymore. If you need to be splinted, splinted. This is the question they will ask you. Which fracture has the highest risk of fat embolism? Fat embolism. Which fracture? What do you think? What do you think? Is it your wrist? Is it your leg? Is it your chest? The answer is what? Long bone. So watch for the question. Long bone fracture, that's where the prioritization will be. It's going to be a long bone fracture, like a femur fracture or pelvic fracture. These are the ones that can lead to fat embolism. Pay attention to that. So let's recap. We have a question. This is to recap what we've done. A nurse is caring for a client that is casted. So casted leg. This is the patient, casted leg, who is reporting pain out of proportion of what you should expect. Morphine is not helping. What would you do if you have an option? Reposition the leg. What would you do? Call ACP, right? The next one is what? Apply ice. What do you think? And then give them more medication. Of course, we already seen this. This is a compartment syndrome. And what are we going to do? We're going to call the provider. Straightforward. Traction room. We're going to the traction room. We've switched gears. We are in the traction room. And then when you went, the weights are on the floor. Right? What do? Do nothing and expect that all can fix itself? What do you think? No. When you see traction on the floor, that's a problem. The word traction means we have to do traction. So I want you to write this down. This is the mnemonic for traction, right? Traction. The T is to check for temperature when you're taking care of this patient. The R, make sure the ropes hangs freely. That's key. The A, make sure everything is aligned. The leg is in alignment. What do you think about C? This is circulation. You got to check vascular enzymes. Make sure everything is flowing. And the T is what? What kind of fraction you're dealing with so that you can know what kind of traction, your type of fraction the individual have. It's very important. And then the I, what do you think? Fluid. They need fluid. The O is what? They should have overhead trapeze, something over the head of the bed so that they can use it to move their upper body. So we call it overhead trapeze. So this is, if you see a question, it said the patient should not move. No, they can move their upper body from the O. And the N is what? No weight on the floor. This is the key. So you should make sure that no weight on the floor. NCLEX love to test you on traction. Action is very, very important. Which traction care action is incorrect? So which one is incorrect? That means you're doing something wrong. Like you see the weight on the floor. So pay attention to that. So therefore, don't forget this, because this is what they will normally ask you. Don't forget, never remove weight. So no weight removal. Don't remove it so far as it's being hanged by the provider. Never rest weight on the floor, not on the floor. Don't make sure it doesn't touch the floor, right? And the last one, always check for neurovascular examination. Make sure it's intact. These are the things. They'll ask you which one action is incorrect. No weight should be removed. Don't change it unless the provider asks you. Not on the floor, and never always do neurovascular check. Typical NCLEX question. Guess what? Let's do that one based on what I've told you. I always trying to give you a question to add it to that. They will say, like, assuming that you have a client is in back traction, right? And then is complaining of what? What is he complaining about? Numbness of the foot. What would you do? What should you do first? Prioritization. Who do you see first? Like this patient. If this is prioritization, what is your next action? Put it down in the comments and let me know. But if you're taking care of a patient who is in back traction and all of a sudden you complain about numbness, I told you check neurovascular exams all the time. This is a bad problem. Therefore, what do? The next thing you should do is assess for alignment and the neurovascular exams. And this is what you do. You check for alignment and you check for neurovascular exams for circulation. These are the two. The AC of traction. That is the buzzword. Every time a patient complains about numbness, go for the AC of what? Traction. That's the key. So this is where we are in this patient. The patient had surgery. He had what? Hip surgery, hip replacement. I'm giving you, if you don't know anything about musculoskeletal, this is the key for you to know for your exams. Patient is now post-hip replacement and his leg is crossed. What do you think? Crossing of the leg. This is NCLEX trap. And this is red flag. We should not have it. Red flag. You should make sure you intervene as much as possible, because we're going to lead to what? Dislocation. And therefore, this is leading us to what are the things you do when the patient has hip replacement or knee replacement. What are your traction and your care for this patient? Hip precaution. These are the things you would do. No, no, no. The leg cannot be crossed. No. Cross leg. Negative. No. You should not do that. You should not bend more than 90 degrees. So no bending more than greater than 90 degrees. That is another key. You should use what? The two legs should not come together. So we call it abductor wedge. So abductor, not adduction, not addition, subtraction. So abductor wedge. Use abductor wedge to put it between the two legs so that the two legs will not come, hip doesn't come together. You should give them elevated chairs. So you should avoid low chairs, right? And you should turn them on the unaffected side. Unaffected side. These are key concepts I want you to know about hip precaution. These are a few of them, very, very important. The another thing too is they're not going to go home without walking. They can walk with the cane, but you have to be able to walk before you go home. Why are we doing all this thing? We want to protect the joint from what? Dislocation. So this is a precaution to prevent dislocation of the joint. So based on that, what do you think is the most common NCLEX complication after hip surgery? You see, they take your content and they flip it. So what are they going to ask you? The most common question about hip surgery, the complication about hip surgery is the same thing. We want to prevent what? Dislocation. And so your question will be based on that. Dislocation followed by what? DVT. These two things. Pay attention to that. So we want to prevent dislocation and then we want to prevent DVT. That's why they go home with anticoagulation. You have to know any anticoagulation they give them, you have to be comfortable to teach them. So these are things I want you to pay attention to. Crash course, musculoskeletal, but these are little ways I can give you all the information so that you can master them. Now, knee replacement is different, okay? It too has its own precaution. What are the precautions you need to institute? So post-op precaution. What are you going to do? The same thing, neurovascular, you got to check. You have to have an ankle pump so that you can move the leg, and then eyes for swelling. And then you have something we call CPM. So they should have something we call CPM, which is continuous passive motion device. Look at it. The word is continuous. It keep on going no matter what. And it's passive. The patient is not doing anything. It's not moving the joint. The device is doing everything. So you use it after knee surgery to gently, continuously move the knee through a set of range motion, helping to prevent what? What is the main thing? Stiffness, reduce pain, and improve circulation. So this is the thing it's doing. You reduce pain, it prevents stiffness, and improve circulation. So it's continuously moving the leg and the knee and allow the blood flow and prevent stiffness because the patient leg will be locked in place with the CPM. And so that is the function of that. Know that. Very, very important. And this, they will ask you. So a nurse note that the CPM machine has been off for 4 hours. What is the next action? You should let the doctor know because we want to worry about stiffness. We should worry about blood flow. And then the motion need to be going on to the knee and it's being off is a problem. So the nurse need to notify the provider as soon as possible. So when you see CPM, it's continuous passive motion device. How are you doing so far? It's a crash course, but you can see I'm not giving you a long lecture. I'm giving you little things that you know that you can use it to answer questions when you see MSK question, musculoskeletal. This is all the NCLEX will ask you. Now, my favorite is amputation. There's key facts you have to know. Most of the time, amputation is all about positioning and phantom pain. So the key is position, safety, and phantom pain. That is very important, and that's what you're going to teach them. expect this question that you're going to intervene. Please know this. These are key facts. When they ask you about amputation, what do? The patient is going to lay prone several times during the day, usually lasting for what? 30 to 40 minutes. And they can do it 3 to 4 times in the day minimum. This will happen after what? 24 hours. Before the 24 hours is fine. They can be whatever you want to be. But after 30, after 24 hours, they need to lay prone 30 to 40 minutes, right? 3 to 4 times a day minimum. This is going to prevent contraction. Very, very key. You got to wrap the stump. How do you wrap it? Figure of 8. What do you do with it? You got to keep it dry. You got to keep it clean. And it has to be elevated when? Only 24 hours. Pay attention. 24 hours only. After 24 hours, that's when you start putting them in the prone position. You have to manage their phantom pain. Let me show you. So this is the individual knee. And then we have amputation here. Now they have something like that. They will think that the leg is there. So they will be thinking about it, doing things as if the leg is there. And these will generate a lot of neuropathic pain. So most of the medication we use is medication that help with the nerve function, neuropathic pain, and that is Neurontin. Gabapentin is your first choice. If you see a question, this is the medication you always will pick for phantom pain. The second one is mirror. You have to give them a mirror so that they can look at it. They can see that, oh, the leg is amputated, and this will help with the pain. So remember, phantom pain is real. It's not psychological. It's a real thing they're feeling. So you got to manage it with medication and gabapentin, or provide some visual issue for them to be able to see that, oh, the leg is not there. And so this is what you will do when you see a question on phantom pain. Now, you're going to see a question between osteoarthritis versus what? Rheumatoid arthritis. This is a free question. Trust me, this is free. If you draw a table, the first thing you have to know, these are the two types of arthritis that shows up on the ankles, osteoarthritis and the rheumatoid arthritis. Don't mix them up. They will mix it up for you. Don't. And if they come, you got it. Use this table, draw it like that, and you passed it. First, figure out what causes it. And what causes rheumatoid? Let's put a rheumatoid here like that. And then let's put osteoarthritis like that. So causes. What causes rheumatoid? It's an autoimmune disease. Osteoarthritis is not. It's usually wear and tear, like your thighs. That's all. So when they give you a scenario, know where it's coming from. What kind of joints are involved? Most of the time, people who have what? Osteoarthritis, what do you think they complain about? Bigger joint. So therefore, this one has to be small. Small joint. Small joint, and it's both sides. Osteoarthritis is usually one large joint and asymmetrical on one side. So only one knee, right? Osteoarthritis, rheumatoid arthritis, both hands may be involved. Then watch for morning stiffness. I want you to know, if you draw this table, there's no question regarding this thing will help. You get it wrong. Morning stiffness is usually for osteoarthritis is very short, right? Very, very short, less than 30 minutes. But rheumatoid, because they're not moving, because they're not moving, usually it lasts longer, and it's like an hour. So that's the difference. When they give you a question, they said the client complained about morning stiffness that lasts for more than an hour, it's rheumatoid arthritis. But if it's less than an hour, it's osteoarthritis. Then pain. What happened to the pain? The problem is rheumatoid arthritis, what do? They need to move to give the pain better. Why? Because the more they move, the less stiff is the joint. So you want them to move. So rheumatoid arthritis pain get better. Osteoarthritis, when they move, they put in wear and tear on the joint. So the pain get worse. That is the difference. And therefore, medication, you can think one is autoimmune. What do you think? We're going to give them immunomodulators. We call it DMARDs, right? Or steroids, because it's an immune system problem. And this one, NSAIDs are fine. So this table, if you draw it, you got it. So if I tell you we have a medication called methotrexate, who are you going to give it to? We have a medication called hydroxychloroquine. Who are you going to give it to? These are all what? DMARDs. You give it to rheumatoid arthritis. Pay attention to that. Pay attention to that. Pay attention to that. Don't forget. That's the key. And what do you teach this patient regarding these medications? Because they affect your immune system, we call it neutropenic precaution. So watch for that. Neutropenic precaution. Don't eat hot dogs. Don't eat fresh vegetables. Drink your own water when you're going outside. Avoid live vaccine. These are little things I want you to pay attention. Put it together. Put the concept together. You can see that you know more than you think. They're going to ask you about osteoporosis. Don't worry about it. It's straightforward. It's going to be a woman who is menopausal, postmenopausal, or menopausal, but most of the time after menopause, older patient. And what is the problem? Risk factors: calcium. Calcium. Therefore, make sure they get calcium and vitamin D. Make sure they're doing weight-bearing exercise. This will help with the joint and the bone. Smoking, avoid it as much as possible. Caffeine is one of the things that they should also avoid it. And of course, something they cannot avoid is age. Therefore, they can't do anything about it. But these are things you have to teach them. Give them calcium, vitamin, weight-bearing exercise, smoking, and avoid caffeine. Common medication you're going to see, they are bisphosphonate. What name do they have? Dronates. Eat in the morning, empty stomach. And then you remain upright for 30 minutes. Why? It causes esophagitis. Irritates the esophagus, so you got to remain upright for 30 minutes. So what happens if you lay down? That's the answer I've given you. Why do you do that? We want to avoid esophagitis as much as possible. Now, gout. Don't forget about your gout. What is the problem? This is crystals forming in the joint. Which joint is involved? Big toe. That's the big one. What do you teach the patient? Classic NCLEX question. I'm just going straight to the point, teaching, because these are risk reduction potential that you may see. So this is the way you always have to go for the teaching. What is the problem? They should avoid purine. Too much purines will cause high level of purine level, and that can lead to gout crystals. What are the things that has a bunch of purines in it? Watch for it. Organ meat. This is the easy way. Don't memorize it. If you think the thing is an organ, and know everybody know what an organ is, then you should avoid it. Your liver is an organ. Your heart is an organ. Your kidney is an organ. Therefore, anything that is an organ, avoid it. So when you see in the question, I don't want you to go and memorize kidney alone. use the word organ meat so that you can avoid from it. And shellfish, they should avoid it. What is the treatment? There's a chronic and acute. This is classic NCLEX. Most people forget. Acute phase means there's nothing you can do, is to take care of the inflammation. So NSAIDs. And the one we use is colchicine. This is the easy one we use. Remember that, colchicine. That is the common one we use. But in a chronic phase, that means we're trying to use maintenance. We're trying to prevent acute flare. So what do? Allopurinol. This medication is a sulfur drug. Therefore, everything you know about sulfur drug, you can apply it. Stephen Johnson is the biggest problem. So what do you teach them? When they're on allopurinol, you tell them, okay, increase fluid as much as possible. Increase fluid as much as possible. And then stop the allopurinol if they develop rash. That's Stephen Johnson syndrome. So increase fluid and stop it, because that's a priority. Therefore, any patient who is taking allopurinol for gout and a report of rash and itchiness, that's a priority. The next thing you do is stop the medication. This is where we have assistive devices. You have your cane, you have a walker, you have a crutches, right? These are the things that they will ask you on the NCLEX. Remember, they love this. It's part of your fundamentals. You just have to provide appropriate teaching. 2 to 3 finger breadth below the axilla. Otherwise, you have nerve injury. You want to prevent nerve palsy. The elbow is flexed, but it should not pass 30 degrees. 20 to 30 degrees is enough, right? And you move the crutches plus the opposite leg together, right? That's the key. Move crutches plus opposite leg together. This is the key. Cane. What do? You hold it on the stronger side. This is key. I'm just telling you that the most common thing they may ask you. There's other thing they will ask you. And you move the cane, then the weaker side, then the stronger side, right? Because the stronger side is supporting you. So the cane, right? Then the weaker side, and then the stronger. That's how you progressed. When they come to the walker, it's the same strategy, right? Walker is the same. You want to protect your stronger leg. So you have the walker and the weak, then followed by the stronger. It's the same thing. Don't pick it up. Push it. Push the walker. Don't pick it up. It's very, very important. So if somebody is using a cane and you're holding the cane on the weaker side, that's wrong. You have to correct them because that's inappropriate. And let me put everything together. What is the problem? Compartment syndrome. What are you worried about? Pain not relieved by pain medication. That's key. When you hear it, that's the buzzword. Traction. What are you worried about? Make sure never on the floor. Post-op patient, hip replacement. You worry about what? Dislocation. So your leg should not go more than 90 degrees. That's bad. And then you should use abductor wedge to keep the legs apart. When you're on DMARD, that's methotrexate, infection. Watch for what? Neutropenic precaution. If they're taking Alendronate, what is that? Take it empty stomach, upright in the morning, right? That's the key. If they're taking Allopurinol, we're going to worry about Stephen Johnson syndrome, but let them drink a lot of water so that they don't form crystal in the kidney. That's key. And if you come to osteoarthritis versus what? Rheumatoid arthritis, remember, one is symmetrical. Which one? Rheumatoid. Causes autoimmune. Rheumatoid. Pain get better with rheumatoid. Stiffness Worse with what? Rheumatoid. Therefore, they have to move, right? And the medication they use is autoimmune. The opposite is osteoarthritis. Long bone, when they walk, you get ahead. The stiff is not that long. Stiffness is not that long. They just need NSAID. And it's due to wear and tear. Very simple, straightforward crash course that I want you to pay attention to for musculoskeletal. What do you think? You just crash musculoskeletal for the NCLEX. This is not everything. There's some few medication, but if you know this, you know more than 90% of the things NCLEX will ask you. There's some pediatric conditions, but this is enough. Thank you for watching. Thank you for subscribing to Adapt NCLEX. If this video helped you, put the comments down, click on the like button, and share it with your friends. And come back for more. Thank you for watching. Bye-bye.